Good morning, everyone. Good morning. Thank you. Good morning. It's a great pleasure for me to introduce Dr. Alan Wasserstein. Dr. Wasserstein received his bachelor's degree with honors from Amherst and his MD from the Albert Einstein College of Medicine. He then did his internal medicine residency and his fellowship in nephrology at the Hospital of the University of Pennsylvania and joined the faculty in 1980. He's had a long and distinguished career at Penn. He actually has done many things within nephrology. He's an expert on nephrolithiasis, but that's not why he's here today. He chaired the Medical Faculty Senate and also served for many years as Vice Dean for Faculty Affairs. During that time, he promoted gender and minority equity in the School of Medicine and lectured extensively within the school on unconscious bias in the hiring and promotions process. He developed the academic clinician track at Penn, the Gender Equity Council, and the Arthur Ashbury Faculty Mentoring Award at Penn School of Medicine. He now serves as Director of Professionalism Initiatives and the Diversity Search Advisor in the Department of Medicine. He developed the Narrative Professionalism Program and established the William Carlos Williams Conference in Professionalism and Humanism. His scholarly interests include his discipline-specific interest in nephrolithiasis, but also professionalism and the history and literature of medicine. Today, his talk is on a very timely topic, unconscious bias, so please join me in welcoming Dr. Wasserstein.
Thanks very much. It's a pleasure to be here today. As was mentioned, I've been lecturing on this subject to search committees to try to improve diversity in our hiring and promotions at Penn, and I really welcome the chance to talk to you about it. Obviously, it's become a very important hot topic. You know, police departments around the country are doing training in unconscious bias because of the tragic killings of young black men, and it's a topic that's on everyone's mind. So, you know, we really distinguish between conscious or explicit bias and unconscious bias. Conscious bias, bias that people will report about themselves, has actually declined significantly in the US in the last 50 years. And at the present time, about 13% of white people identify themselves as racially biased, but that's down a lot from before. The majority of people, however, has unconscious or implicit bias, which is bias that expresses itself in behaviors rather than verbally, in feelings of anxiety and discomfort, rather than in words of hatred or contempt. So in medicine, we're interested in bias in two main areas. One is in hiring and promotions in academic medicine, and the other is in racial and gender disparities in medical care. And I'll talk about both of those things. I'll begin by talking about the social psychology of unconscious bias, how we measure unconscious bias. Then we'll talk some about unconscious bias in promotions, which is most of the literature is about gender, and then about unconscious bias and health disparities, and most of that literature is about race. And finally, we'll talk about some ways of overcoming our unconscious biases. So some principles of social psychology. We talk about schemas, which are deeply embedded generalizations about our environment that organize and simplify complex situations and give people control. These are evolutionarily adaptive. These are ways of processing your environment quickly, making quick decisions. They're mostly, for the most part, very useful things. However, in certain cases, they become counterproductive. And one of those is what we call definition stereotyping, which is using social categories such as race, sex, or gender orientation to characterize people and make judgments about them. People are infinitely various. We have many, many different things about us, and we're like snowflakes. We're all different, and yet you can assume that people are all the same and homogeneous based on a couple of characteristics, and that's a terrible error to make. So as far as schemas go, they're really unconscious reactions and behavior. And they are nonverbal, they're often negative, we call them implicit, and they're slow learning. They're based on observations made over time, as distinguished from conscious beliefs, which are things that can be expressed verbally, that we learn very quickly, and are obviously conscious. So the development of schemas begins very early in life. Examples of unconscious schemas, where they come from: watching mommy serve daddy at the dinner table, watching daddy pay the check at the restaurant. These become schemas that are embedded before the age of 5. Kids have these schemas. Another important concept here is outgroups versus in-groups. So simply dividing people into us versus them leads to bias. And it's quite amazing. You can do studies where you just divide a bunch of volunteers into work groups, put them all at different tables, then ask them later, how did your group do compared to the rest of the room? Oh, we were in the top quartile. People tend to think their own group is doing great and doing best. People are most comfortable with people like themselves, and the in-group tends to regard the out-group as fairly homogeneous. They're all like the same. We don't distinguish between them, whereas they see members of their own group as individuals. Healthcare providers, as we realize, are likely to be white and middle or upper class. Like any in-group, they're more comfortable with people like themselves, and they're likely to have implicit biases towards minorities and the poor. So if a white upper-class woman misses an appointment, we think, okay, she missed her appointment. If it's a black poor person, we say, oh, that person's non-compliant. These are the kinds of biases that can crop up. You're all aware of the familiar explicit biases. One is that women have communal traits. They're nurturing, nice, supportive, helpful, and sympathetic. They make good homemakers that wouldn't be great for the workplace. Men are strong agents. They're decisive, inventive, strong, forceful, independent, highly competent. Racial stereotypes: whites are educated, intelligent, successful, adherent; blacks poor, uneducated, aggressive, lazy, non-adherent. These are not implicit biases. These are verbally expressed. Implicit bias is a different sort of thing. Manifestations of implicit biases tend to be behavioral rather than verbal, such as measures of interest, eye contact, or not making eye contact, or anxiety, like a lot of eye blinking is a manifestation of anxiety. Implicit bias is expressed and perceived outside of conscious awareness. And this actually leads to a whole theory of racial misunderstanding, which I think is quite interesting. I'm not sure it's totally validated, but it's been clearly shown in several studies that blacks have heightened attentiveness and sensitivity to nonverbal cues of bias. Whites are unconscious of their bias, explicitly try to be colorblind about race, possibly because they're uncomfortable about race, pretend it doesn't exist. But their unconscious bias may manifest in nonverbal behaviors that are picked up by blacks. So from the black point of view, it looks like whites are hypocrites. And it's no wonder that blacks don't trust whites, and much more than whites believe that racism remains a significant problem, whereas whites tend to deny that that's the case. So a lot of this stuff begins with the Goldberg experiment in 1968. This is a very well-known experiment. You may have heard of it. It's what Goldberg did was present essays to students, and the same essay, one authored by a male name and one authored by a female name, and student participants evaluated these essays better if there was a male name attached, unless the topic was a feminine topic, in which case they would evaluate the woman's essay as better. And this kind of a study has been repeated numerous times. For example, in the matter of hiring with race, applications were sent out to real businesses with either African-American names such as Jamal or white-sounding names like Greg, and applicants with African-American names had to send 15 resumes to get a call back, whereas white names sent 10 resumes to get a call back. White names yielded as many callbacks as black names with 8 additional years of experience. So this is the Goldberg experiment done with race. Teacher evaluations. 4 online course discussion groups, 2 were led by a man, 2 by a woman. In 2 of the groups, the discussion leader identified himself or herself as of the opposite gender. So as for the course as a whole, there was no difference in course ratings between the male and female teachers, but student ratings were higher when they thought that the course was being taught by a man. Same experiment. Symphony orchestra auditions. This is quite interesting. Orchestras used to be dominated by male players, and some years ago, they started doing auditions blind, so they did them behind a curtain. They had the women take off their heels or wear socks, so you could not tell if it was a man or woman, and the representation of women on symphony orchestras has increased dramatically since then. So how do we measure unconscious bias? Unconscious bias is measurable with widely available web-based tools, and it's quite widespread. So despite the decline in self-reported conscious or explicit bias and an increase in egalitarian and unprejudiced conscious beliefs, there's still a lot of unconscious bias around. So we have a test that's available online. It's called the implicit association test. And I'm going to read this. You really can't get the sense of it unless you take the test yourself, which I strongly urge you to do, by the way. I'll give you the website in just a minute. But the IAT asks you to pair two concepts, for example, young and good or elderly and good. The more closely associated the two concepts are, the easier it is to respond to them as a single unit. So if young and good are strongly associated, it should be easier to respond faster when you're asked to give the same response, the E or I key on the computer, to these two. If elderly and good are not so strongly associated, it should be harder to respond fast when they're paired. This gives a measure of how strongly associated the two types of concepts are. The more associated, the more rapidly you should be able to respond. And it's very hard to game this. You know, when you take it, you have to go at a certain rate, and it measures the rapidity of your associations. So here's the website. I wish you'd take it down and do take this test. You can take it for various kinds of bias. You can take it for bias against gays, transgender, African Americans, Jews, Muslims. There's a whole variety of different tests. The one for whether you like science or not. Banerjee, a social psychologist at Harvard, has found that the majority of all subjects test as biased against people who are black, gay, elderly, and Arab Muslim. Whites largely show preference for whites, but many others exhibit bias against their own group. About half of blacks test negative towards blacks, 36% of Arab Muslims test negative to Arab Muslim, and 38% of gays show an automatic preference for heterosexuals. And this observation fits with the fact that women, like men, evaluate women's performance or dossiers lower than men's. Quite surprising. An example of this is a study done in Australia of bus drivers. They're twice as willing. They used testers who came on the bus with their fare card depleted of money and asked the bus driver, can you please give me a ride? I don't have a valid card right now. And they were twice as willing to let white testers ride free as black testers, 72% versus 36% of the time. The bus drivers showed relative favoritism towards testers who shared their race, but even black drivers still favored white testers over black testers by 83% versus 68%. So there are problems with the implicit association test, reproducibility, the order in which you take the tests. I think the in-group effect is very strong. I always wonder about the test, because I think there's a natural bias to regarding the in-group or the dominant group in society as good and associating it with good. And what that means in terms of prejudice to me is not at all clear. It just may mean that we associate the dominant group with benefit. It doesn't necessarily mean prejudice. I do wonder about that. But the real question with the implicit association test is, does this correlate with behavior in the real world? And we'll certainly talk about that in a medical context. Before we do that, I would like to talk about some studies done among policemen. And these are shooter bias studies, obviously very relevant to the things we're worrying about right now. These are studies that were published, that I found out about in Police Chief magazine, which I don't think most of you are subscribing to. But one was a study done in 2005. 50 police patrol officers, mostly white. These were mostly beat officers that walked the beat. And they had a computer-simulated shoot or don't shoot scenario. So they were shown a white or a black man holding either a gun or some benign object like a wallet. And some officers were more likely to shoot unarmed black than unarmed white suspects. With training or repeated trials, they were able to eliminate this bias. So this unfortunately confirms our fear that unconscious bias may be affecting the police. However, same study was done in 2009, a much larger study. These were a whole policemen of they had different jobs, SWAT team members, administrators, all kinds of policemen, mostly white, and they also had community controls. And in general, police were slower to make correct decisions when faced with an unarmed black man or an armed white man, but they showed no bias in the decision to shoot. On the other hand, community controls showed a clear tendency to shoot at black targets. So here's a study that validates or is good for police behavior. And the New York Times interviewed the author of this study when it came out, and he said, "We've tested thousands of subjects with consistent results. Only police officers showed no bias in the decision to shoot. So all the other occupations, all the other community controls tended to show this bias. Police did not." So to me, this is really interesting because it reminds me of the implicit association test. Again, there's a discrepancy between the rapidity of association. The police do take a little longer to make their decision when it's an armed white man or an unarmed black man, but they still make the right decision. So the implicit association test is telling us something about their biases, but you can overcome it in real-world behavior. And that may mean that the implicit association test does not necessarily predict your behavior. It also means the training is very helpful. Does the IAT, the implicit association test, indicate that you are prejudiced? The answer to this clearly is no. Prejudice is a conscious attitude, a negative attitude towards a group. It is not this unconscious biological tendency that we have to in favor of dominant groups. And you can misuse or use the IAT. For example, I think a valid use of it would be to guide personal decisions. Should I go into science, for example? You can take the IAT for science and see if deep down you actually don't really like science, or you really do. And that would be a valid use of it. On the other hand, to make a judgment about somebody, let's say give them the IAT, show that they're prejudiced, and say you can't serve on this awards committee or this search committee, you have problems. That's an invalid use, because really this unconscious tendency is found in a large majority of us, and most of us overcome it with conscious behavior. So I'd like to talk now about unconscious bias in hiring and promotions. You all know about the glass ceiling. This happens to be an exemplification of the glass ceiling in an Ivy League medical school that I happen to know pretty well. And this is the proportion of women faculty by rank. Assistant professors, 38%, associate professors, 26%, and only 15% of full professors are women. Now, these data are a few years old, but it's still not that long ago, and they haven't changed that much. And women have been half the medical school class for at least 20 years, and that's long enough for people to get promoted to full professor. And it really hasn't happened. So there might be a pipeline problem here, but more likely there is some bias against women. So we speak of a glass ceiling for women or minorities, and a glass escalator for men or majorities. Before I go into some of the unconscious bias stuff, I just want to mention, which I hardly need to mention, I'm sure you're all aware of this, the importance of diversity. Most important, it's just the right thing to do, is to hire people of diverse backgrounds. It also has advantages for the institution. It broadens the talent pool from which you're recruiting. And also, and this is something that people are not that aware of, diverse groups are more creative and more effective than homogeneous groups. And this has been proved in a few studies. Here's one of jury deliberations. And they compared an all-white jury to a racially diverse jury, and the racially diverse jury performed better in almost every respect. They deliberated longer, they discussed more case facts, they had fewer factual inaccuracies, they had fewer uncorrected inaccurate statements. It was just a more alert and better performing jury. And not necessarily because the racially diverse members were smarter than the white members, but because people, I think, on my interpretation, people get more attentive in a racially mixed group, and they're more attentive to detail and probably make better decisions. So diverse organizations are actually, for their own sake, do well to keep their diversity. So schema's bias are evaluation of performance. Women and the past work performed by women typically receive lower evaluations than men and the work performed by men. And notice when I talk about hiring, I mostly talk about gender because that's really where most of the work has been done. Lower expectations of future professional competence bias the interpretation of actual current performance. So we begin really with these gender and race schemas and with a lack of critical mass among the group. And that leads to evaluation bias. We see few women, few minorities on the faculty. We assume, oh, they don't belong there, unconsciously. And we also have these gender and race schemas that have developed since our childhood. It leads to evaluation bias. We evaluate their performance as worse than it actually is. Disadvantage accumulates, there's a lower success rate, and that feeds back. We have continuation of lack of critical mass of women and minorities on the faculty, and it feeds back on our gender and race schemas to reinforce them. So I'll give you a computer simulation here. This is a little bit of a tricky study to follow, but this is not real world, but it just shows how small a difference in evaluation between groups can make a large difference in the composition of an organization. So we assume this is an organization of 8 levels, 500 employees at the bottom, 10 employees at the top, 50% belong to a favored group, let's say men, and 50% belong to an unfavored group, let's say women. Evaluation scores are normally distributed. The highest scores get promoted. We assume 15% annual attrition until the organization is staffed with all new employees. Now, suppose you give bias points to the favored group, so they have a 1% increased evaluation score or a 5% increased evaluation score. What happens? Well, we see this here. The red line, oops. So the red line shows no bias. So we have the entire organization is staffed 50-50 with men and women. The yellow squares show a 1% bias. And at level 8, the highest level of the organization, only, 35% of the employees are women and 65% are men. And even worse if there's a 5% bias. Well, I defy you to detect a 1% bias in people's approach to other people. That could be an unconscious bias that you would never, ever detect experimentally. And yet it could have a profound effect on the composition of the organization. And that's one of the attractive arguments about unconscious bias. It's also a little unscientific. You really can't disprove it. You can't test it because it's so minute, and yet it could have a profound effect. This is a study from Nature in 1997. This is the Swedish Academy of Sciences. They were giving an award or grant, and they were comparing the performance of their applicants, and they used a competence score to make these awards. And these investigators created a system of impact points, totally objective. All they used was the papers that were published by the various applicants and the prestige of the journals in which they were published. They calculated an impact score from those two kinds of data, and look at the difference between men and women. For a given number of impact points in terms of papers, men got evaluated much higher by the committee that was evaluating than women did. And this is kind of typical. Unconscious bias, I presume unconscious, leading to a lower evaluation of women's performance. One of the causes of this is in the letters of recommendation. It's quite an interesting study. 312 letters of recommendation for medical faculty hired at a large US medical school. The letters for women versus men were shorter. They had terms of minimal assurance, gender terms like intelligent young lady, stereotypic adjectives like compassionate as opposed to successful, more grindstone adjectives for the women like hardworking and dependable, fewer standout adjectives, more faint praise like it's amazing how much she has accomplished, which again is really a negative way of putting it, and more doubt raisers. I love this one. It appears her health is stable. Even her health becomes it's questionable. And then when you look at the words that follow the possessive, her is often more likely to be followed by training and teaching, and his is more likely to be followed by research, skills, or career. Likewise, her is more often followed by a personal description. His is more likely followed by publications, CV, patients, and colleagues. And this is real. I've been on the promotions committee at Penn, and when you look at letters, this is in there, and you can find it if you look closely. And you've got to be aware of it. Try to keep it out of your own letters, and be aware of it when you're reading letters about people. Another issue is shifting standards. People shift standards to justify a reasonable choice. So subjects were told to choose between two candidates on the basis of education and experience. One candidate had more education, and one had more experience. When given only initials, The candidate with more education was chosen 76% of the time, and education was rated most important. When a male name was given to the candidate with more education, the male was again preferred by 75%. But when a female name was given to the resume with more education, and a male name was given to the resume with more experience, less than half the evaluators now picked the person with more education, and less than a quarter now said that education was the most important characteristic. So because they'd found a candidate that they liked, i.e. a male, they changed their criteria, no longer regarded education as important because that male happened to lack education. Another very important point is having time to focus. So people are more likely to stereotype when they're distracted, tired, rushed, or otherwise cognitively burdened. So they presented these volunteers with dossiers of men and women, and during low attentional demand, they rated the two dossiers comparably because they were comparable. But the men's dossiers were rated higher than the women's during high attentional demand. So if you distract people and make them tired, they will tend to default to their stereotypes. So the conclusion is when multitasking and pressed for time, evaluation defaults to prescriptive beliefs, and one has to avoid that. And this one sort of makes sense. Ambiguous qualifications will make a bias more prominent. So this is a study of white students in 1999 reporting less racial prejudice than in 1989, which again is consistent with the whole trend in America in the last several generations. In both time periods, they recommended whites and blacks equally often when qualifications were clearly strong or weak. When qualifications were ambiguous, they recommended whites more often. So on the margin, in the borderline cases, the unconscious bias tended to kick in. And finally, an example of selection gone awry. The NIH gave Pioneer Awards some years ago, about 10 years ago. And in the first round of these Pioneer Awards, only men were chosen. Now, how did that happen? There was no face-to-face discussion about applicants. There was some of the criteria where they wanted leadership and risk-taking, which are things that people unconsciously identify with men. There was an emphasis on self-promotion, and men tend to promote themselves better than women. Weight was given to letters of recommendation that were undoubtedly biased. There was time pressure on the evaluators, and 60 of the 64 judges were men. They wound up with no women receiving an award. The following year, 5 of the 13 awardees were women. What had changed? There was reduced time pressure on the reviewers. They removed the references to high-risk research and intrinsic leadership. There was a higher proportion of women in the applicant pool. There were more women on the review committee, and women were specifically encouraged to reply. Now, the fact that there were more women on the review committee the women aren't necessarily that much less prejudiced or less biased than the men, but the presence of a diverse review committee tends to make for a better, more sensitive, more alert review committee. So that's what I'll say about hiring and promotions. I'd like to turn to healthcare disparities, which is the other big issue in medicine for unconscious bias. There's tremendous evidence for disparities in healthcare. And these pie charts just show the studies that have been done. And in orange, you see the studies that showed a racial or ethnic difference in healthcare delivered. And you can see that it's overwhelming. Most studies have shown a bias against minorities. There was a seminal study in 1999 by Shulman et al., and I remember reading this study. It was a national meeting. Primary care physicians were shown videotapes of actors complaining of chest pain. And though the correct diagnosis of coronary artery disease was made by these PCPs, blacks and women were less likely to be referred for further testing. Now, I think at the time we knew there was racial disparity, but I don't think people realized that part of the problem was bias among providers. Now, some of this might have been the over-application of population statistics. Some physicians might have felt, well, women just don't have heart disease. But they made the diagnosis of coronary disease. But maybe that biased them not to recommend women for cath. It doesn't explain why they didn't recommend cath for black patients. And after that, in 2003, the Institute of Medicine came out with a influential document, Unequal Treatment, that pointed to this tremendous problem we have in racial disparities and some gender disparities of healthcare. So why do we have health care disparities? One is certainly a very important reason is socioeconomic differences. Poor people have less access to care. They have reduced health literacy. There's differential exposure to health hazards or stressors in some populations. There's a difference in health-related behaviors in some populations. But now we recognize there's maybe some explicit, but mainly implicit provider bias. And there are 4 ways that clinicians can be biased. We can use stereotypes to make clinical decisions. We can give differential weight to our findings on exam depending on the patient's history and appearance. One of these is conscious, overt moral rationing. Doctors in general do have a bias about adherence among minority populations. And a doctor might decide that based on adherence or based on social support, a certain treatment or diagnostic procedure should not be recommended. And finally, unconscious behaviors can affect the patient's decisions, adherence, and satisfaction. So physicians have very little explicit racial bias. I mentioned that racial explicit bias is declining in the United States, and physicians, a well-educated group, have very little explicit bias. As I mentioned, though, there is this bias about adherence among black patients. On the other hand, physician implicit bias has been linked to treatment decisions in clinical vignettes and may affect doctor-patient communication and occur in real life. And one problem is implicit bias is harder to control than conscious bias. Implicit bias is outside, by definition, it's outside of awareness. It's often expressed in behaviors, and therefore it's more able to manifest itself. Other reasons why we might default to stereotypes. Stereotypes are labor-saving shortcuts in clinical decision-making. Seeing people as individuals takes extra cognitive work. So we're more likely to default to stereotypes if we're busy with other tasks, distracted, tired, under time pressure, or anxious. Well, guess what? That's our life. That's what we operate under. So people default to these stereotypes under the stressful time pressure and difficult situation which we're often working. Another issue which I've realized for a long time is we basically teach our medical students and ourselves practice a kind of racial profiling in the sense that we rely on population statistics to a large degree. So as medical students, you're often taught, what's the patient's gender, what's their age, what's their race. That immediately leads me to certain diagnostic possibilities. And it's how we narrow it down, it's how we think. But if you over-apply population statistics, they basically function like stereotypes. And so we're kind of primed to do the equivalent of what we call racial profiling among police. It's kind of what we do when we use population statistics in medical diagnosis. So I could give you hundreds of examples of bias leading to disparities. I list 3 on this slide, but really there are literally hundreds of papers on this topic. But for example, providers rated their black patients as less educated and in less demanding careers than their white patients, even though the medical record explicitly indicated that education and occupation were equal to whites. In another study, providers rated black patients more likely to abuse drugs, independent of age, gender, income, or severity of illness. Another study, blacks were less likely to get cabbage when controlling for other factors. Only race could be implicated in that decision. And there are papers on differences in care of patients with prostate cancer, recommendations for kidney transplant. It's all over the place. Now, what does unconscious bias have to do for this? This is the first vignette study on this subject. So vignettes are a pretty good way to judge clinician performance. You basically give people a case description and you ask them, what would you do? In this study, they gave a case in which the use of a thrombolytic agent for an acute coronary syndrome was being questioned. And as you can see here, in the group with low implicit bias by the implicit association test, the recommendation for a thrombolytic was lower in whites than in blacks. Not quite sure why that was, but it was. However, in the doctors who had high unconscious bias, now they were more likely to recommend thrombolytics for the whites than for the blacks. This showed us a significant effect of your unconscious bias to predict your clinical decision making. So it sounds pretty ominous, but We then have a couple of vignettes, another vignette study. This one is done at Hopkins, just published last year in JAMA Surgery. 215 Johns Hopkins acute care surgical clinicians ranging from attending, fellow, and resident. They were asked to respond to 8 clinical vignettes, and they compared their responses on the clinical vignettes with their implicit association test scores. There was no association in multivariable analysis of unconscious race or social class bias on the IAT with their vignette-based clinical assessments. Unconscious bias had nothing to do with their decisions. So here's a negative study on unconscious bias. And here's a pediatric study. 95 pediatricians. They had a 58% response rate. 65% of them were women. They had 4 case vignettes on UTI, ADHD, asthma, and postoperative pain. And there was no correlation of the IAT scores with racial preference in the vignettes. So their unconscious bias did not seem to affect their clinical decisions, except in one case. In the case of post-op pain, where the vignette talked about a 14-year-old boy who'd come back to the emergency room after surgery, the IAT did correlate with a lower likelihood of physicians giving narcotics to this kid. Now, we know that there's a lot of conscious bias about use of narcotics in African Americans, so that may correlate with this unconscious bias. But again, a very mixed study. Most of these vignettes the unconscious bias did not affect performance. So conclusion, we have conflicting evidence of the role of implicit bias in vignette studies. Myself, I wonder if one possibility that occurs to me is some vignettes might be more challenging than others. If you have a clear-cut answer, that's a situation where the unconscious bias doesn't tend to kick in. If it's hazy or not as clear, then the unconscious bias might kick in. So it might be that some of these studies that showed a role for unconscious bias had cases that were a little more ambiguous. So the most important question is, can we show a relationship between implicit bias on the IAT test and outcomes of care? So here's a study of 138 primary care physicians and their 4,794 patients who had hypertension. And the black patients had treatment intensification, meaning their meds were modified appropriately, or at least the same as in whites. They had lower adherence and worse hypertension. Latino patients had equivalent treatment intensification to whites, lower adherence, but similar hypertension to whites. Even though they adhered less well, their blood pressure was better than in black patients, which to me only says that black patients have more of a problem with hypertension. But bottom line here, there was no correlation of clinician implicit bias with any outcome. So again, a negative study. And we really don't have any other studies that I know of to show that implicit bias correlates with outcomes of care in the real world. What we do have is some very impressive studies of minority perceptions of care. So we know that minorities judge that their care is inferior to that of whites. Minorities rate interpersonal quality of care more negatively than do whites, and they experience poor communication with their physicians, particularly in race-discordant relationships, like a white physician with a black patient. When counseled on options for treatment of lung cancer, black patients were more likely than white patients to feel less supportiveness, less partnership, less information received, and less trust. And this is typical. There are numerous studies that have shown this. Now, in support of this is also the observation that when treated by black doctors, black patients are more satisfied with the encounter and with their medical care and more likely to schedule and keep their appointments. We have some studies that look at implicit bias in this situation. Should we say, we know these differences exist. What role does implicit bias play in these situations? So here's a study of 134 clinicians and 2,908 patients. Again, as always, very low clinician explicit bias. So explicit bias, what we call conscious racism, did not play a role. Clinicians with more implicit bias were rated lower in their patient-centered care by black compared to white patients. Latinos rated clinicians lower than did blacks and whites, but there was no relation to implicit bias. Sort of correlating with the idea that black patients may be more sensitive to cues, behavioral cues of bias. Here's another study, which I think is well done. 40 primary care physicians and 269 patients in an urban community practice. the doctors had implicit association tests for race, and for one they made up. They made up their own implicit association test studying adherence as related to race. The question of, was there a sense, an implicit bias of doctors to assume that minorities will adhere less well than white patients. And their measures were audio tape measures of the visit communication. So they did audio tapes and then analyzed them, and also had the patients rate the encounters. So again, there were two different implicit association tests. So one was just the standard race test that is available online that you can take. And when there was increased race bias among physicians, it led to blacks being less happy with the visit, less perceived respect from the clinician, less liking of, less confidence in, and less likely to recommend the physician. For white patients, if they were taken care of by a patient with increased pro-white bias, they had an increased perceived respect, they were more likely to believe they were liked by the physician, but they were less likely to perceive the patient as participatory. So even the white patients had a little bit of a problem with the patients who had a lot of implicit bias. Why that is not totally clear, but somehow these physicians who test high for implicit bias, there's something the white patients are noticing about these physicians that is not ideal. And then with the other implicit association test, the one for adherence stereotyping was associated for blacks longer visits and a slower pace of dialogue, less patient-centered dialogue, lower trust, and lower confidence in the clinician. For whites, shorter visits, more rapid pace of dialogue, less clinician verbal dominance. In other words, the doctors didn't spend so much of the time talking, they let the patients talk, and more patient-centered dialogue. For both whites and blacks felt there was less involvement in the treatment decision, which is interesting again. So this testing high for implicit bias on the implicit association test predicted that patients would feel less involved in decisions, even white patients. So there's something about those interactions that's odd, and that we don't know exactly what that was. But the conclusion from the paper is that blacks are at greater risk than whites for narrowly biomedically focused visits with restricted patient input in the psychosocial and lifestyle realm. So I think that's clear. And many studies, not related to implicit bias, but many studies have shown that patient-centered communication is associated with trust, recall of information, better adherence, satisfaction, continuity of care, and outcomes. So it seems likely that if what's observed in this study is true, that implicit bias predicts a more narrowly biomedically focused visit, that should have consequences for medical outcomes. However, that hasn't been proven yet. So to conclude on this area, the theoretical case for a role of implicit bias in healthcare disparities is excellent. The theory really makes sense, and it does accord with a lot of the data. However, the vignette studies that I mentioned to you are contradictory. There is little evidence so far of an effect on clinical decisions in practice in the real world. But I think best established is the effects of implicit bias on the doctor-patient communication. Very suggestive, predicts an effect on outcomes. However, that hasn't been proven yet. So I haven't quite drunk the Kool-Aid on this. I'm a little skeptical about the proof of the role of implicit bias. I happen to think there's something there, but it really hasn't been nailed down. So finally, how can we mitigate unconscious bias? People can learn to reduce their reliance on schemas by conscious effort or by using imagery. So for example, you can have people imagine counter-stereotype imagery. So before taking the implicit association test with regard to gender, you can have the subject imagine a strong woman, which is counter-stereotype. Or you can have them imagine a storybook princess or a Victorian woman, which would be pro-stereotype imagery. Or they can imagine something totally neutral, like a house. And it turns out that significant reduction in measures associated with unconscious gender assumptions occurs following counter-stereotype imagery. So you do better on the test if you imagine a strong woman, as opposed to imagining a Victorian woman. Another way of doing this is to show images of admired and disliked individuals, and this seems to combat automatic attitudes. So the implicit association test was done after pictures of 40 well-known individuals were shown to the volunteers, 10 each in 4 categories: an admired black, like Denzel Washington, an admired white, Tom Hanks, A disliked black, Mike Tyson. A disliked white, Jeffrey Dahmer, the mass murderer. And the white preference effect was smaller after seeing positive black exemplars immediately and at 24 hours, which just goes to support the idea that we need more women and minority physicians and more on the faculty so that people are seeing that and it influences their unconscious bias. So I'll show you some pictures to influence you. Charles Drew, this is the African-American who developed ABO blood typing. Barbara McClintock, Nobel Prize winner in genetics. Denzel Washington, very popular among the women in my family. So how can we, so you can almost think, maybe before I start my clinic, I should just leaf over some pages of women and admired black individuals to influence me. I haven't heard of people ever recommending that, but that's sort of the implication of this sort of information. I think more realistic is to just engage in conversation with women and African Americans and other minorities as a way of modifying your biases. So this is a study of modifying the implicit association test for race during medical school. So they gave the IAT for race to students, and a very large number, as you can see, 49 medical schools and over 3,000 students. They gave it in the first semester of medical school and the last semester of medical school and looked at the changes. And they found that what modified the IAT was simply having taken the IAT at some point. Now, taking the implicit association test is something you would only do, pretty much, if you were in a cultural competence class. So they presumed from this study that students who'd had a course in cultural competence and therefore had taken the IAT, that had influenced their score. They had become less implicitly biased. On the other hand, hearing negative comments from your attending or your resident actually worsened scores on the implicit association test. And whether you had an unfavorable or favorable interaction with African American physicians also affected your implicit association test scores. So the main thing I draw from this is the fact that the cultural competence training did seem to have some benefit for medical students. And finally, I have an anecdote. I've given this lecture to various divisions and departments at my school, and after one of them, a white faculty member told me that she took the IAT. She tested strongly positive for bias towards whites. She was absolutely mortified. She really reacted very negatively. So she embarked on a program of greeting, smiling at, and engaging in conversation African Americans in diverse situations, from the workplace, on subways, wherever. She made a real effort to interact. And on the retest, she had minimal, if any, preference, which is quite a striking anecdote, and I think gives us a little clue as to how we can deal with this test. So, recommendations: how can we mitigate our unconscious bias? One is we can take the implicit association test. I think that's really important. To make it, otherwise, this whole thing feels kind of unreal to you. Once you take the test, and you're very likely to have bias, by the way, and it's nothing to be ashamed about. The vast majority of people do have bias. Second thing is empathy, and that's simply seeing people in terms of personal characteristics instead of in terms of their group membership. So having casual conversation with patients or colleagues from other groups, the way this faculty member that I know did, would be one way to do that. Atul Gawande, in one of his books, says you should begin every clinical encounter with a reference to some non-medical subject, like did you see the Phillies game, the weather, whatever. Start talking about something non-medical and establish a relationship. Or finally, imagining yourself in the other person's shoes with regard to their healthcare attitudes and their behaviors and their decisions. So these are ways that you can, I believe, get past the in-group, out-group thinking. Also, group membership. You should think of yourself and the patient or yourself and the consultant as members of the same team, working together for the patient's welfare. So you have a dual identity. You're both the doctor and you're also a team member like the patient. You and the patient are both on the same team. You and your consultant are both on the same team, taking care of the patient. You have two identities. And you should emphasize shared decision making. So make your decisions with the patient as a kind of a colleague. And that reduces your sense of thinking yourself as part of the in-group and the patient is part of the out group. And I think that makes a lot of sense. And finally, if we could create less stressful environments, easier said than done, if we could minimize fatigue, overload, time pressure, we would not so easily default to stereotypes. And this is, these high-pressure environments have been shown to be more prevalent in settings that predominantly treat minority patients. So it's certainly an issue for us. Of course, getting rid of this kind of high-stress existence that we live is not only our job, it's also administration's job. So we're not totally in control of this situation. And finally, I just give some recommendations for search committees. Use a checklist with standardized multiple criteria for evaluation to avoid the shifting standards problem. You don't want your standards to change during the search because you found somebody that you liked. Have face-to-face meetings, so don't blow somebody off in an email, but actually justify your decisions face-to-face. Make sufficient time for decisions. This is a big issue. I'm supervising a search committee in one of our divisions in which we have an eminent African-American faculty member who is, just can't find time to make the meetings. And I said, unacceptable. You can't be on the search committee if you can't take part in the meetings. You have to have time for these decisions, and you have to meet face-to-face. Look for bias in letters of recommendation. We talked about that. Put women and minorities on the search committees. Again, women and minorities may have their own unconscious bias, but the fact that you make the search committee more diverse makes it a stronger committee. And expand the pool from which you recruit, so don't recruit only within the usual old boy networks, they're called, but try to expand the pool of applicants. And this is the hardest one, I think, is the last one. And I haven't seen other people make this recommendation, but beware relying on your comfort level in the interview. We interview people because we want to feel, can I work with this person? And the more comfort you feel, it's more likely to come from you being like that person being like you. That's the person you're comfortable with. It tends to reinforce, your biases tend to make you like people that are like you. You'll never really diversify if you're only hiring the people that make you comfortable, because they're likely to be just like you. And if you can get past that, which I think is very hard to do, I think those of us who rely on interviews to choose new hires would be very reluctant to give up the interview. But I think the interview itself kind of favors in-group mentality. So conclusions, implicit bias probably plays a significant role in the glass ceiling and in healthcare disparities. Conscious, unhurried deliberation can mitigate it, but we often don't have the time for that. Implicit biases can also be lessened by empathy, shared decision-making, and perhaps cultural competence programs. Above all, I would recommend, I hope you will, take the implicit association test in multiple areas just to convince yourself that you need to take steps to confront your own biases. Thanks very much for your attention. Not sure how much time we have, but. I'm sorry, I couldn't quite hear.
Was there any research done about diversity increasing one's attitudes or awareness of racial bias versus policing behavior in front of peers?
Well, I think the whole field emphasizes the fact that a diverse environment lessens implicit bias. When you see that there's a critical mass of women or minorities on the faculty, it lowers your sense that that the positions of honor and of achievement belong to white people. That sense gets undercut by seeing people in those positions. So diversity itself, yeah, it's kind of a positive feedback loop. Diversity leads to more diversity.
Any other questions or comments? So, what steps can be taken if one is in a position where you are observing these biases? And where do you start in an institution as far as trying to make these type of changes?
I think administration has to start with administration. I think training of some kind. I mean, police departments are doing training on unconscious bias, cultural competence courses for medical students, and maybe training on unconscious bias for faculty, trying to ensure diversity on search committees. And there are various steps that one can take. I think there are things you can do at the individual level that I mentioned, and there's some things you can do at the institutional level. For example, trying to decrease the time pressure on people, increasing the length of visits, which is kind of hard to do because there's a business imperative in our academic medical centers too, and that's in conflict with the idea of giving people more time to interact with their patients. It's not easy, but there are things that one can do.
And Alan, why don't you say something about the diversity search advisor section? I think that's a really.
Well, yeah, so I'm a diversity search advisor in the Department of Medicine, and I usually meet with the search committee at least once. I give them a short version of this presentation, and I make sure that I have to approve the composition of the search committee, so I make sure there are women and minorities, which, by the way, is kind of a tax on women and minorities. There's only a few of them, and they have to be on these committees, and it's hard to get enough representation from women and minorities. And I make sure the processes that the search committee is following follow some of these recommendations that I mentioned to you, like using checklists and so forth. So, we try. How effective this is, I have to be honest, I'm not sure. Because I think a lot of searches begin by the chief of the division or the department chair hearing about somebody, wanting that person, and then creating a search that is really a sham search because they want to hire somebody that they've heard about already, that they know about. And a lot of searches are like that. And hiring people away from other places is not easy to do. And to put diversity in the mix, it just is a lot of trouble for people. So I think it's an uphill battle, really. Yeah.
Thank you for a fascinating and intriguing answer. I'm thinking about this topic in the context of recruitment for graduate medical education. So there's been an increasing awareness over the past decade or so that emotional intelligence plays a really critical role in the effectiveness in graduate medical education, i.e. during residency programs with intelligence. People who get into trouble tend to be the ones who have poor emotional intelligence rather than just intellectual IQ. And it seems that the interview is the best place to detect that, to assess that, because the application is fine and great, and it's on paper. And people can go as far as actually downloading the personal statement these days. So how do you balance the need to assess interpersonal skills, emotional intelligence, against the need to avoid using emotional bias?
That's a great question, and I think you're exactly right. I think the interview has some invaluable things that it can do. In the specific case that you mentioned, yes, I think the interview is crucial. And you're right, you'd have to balance the interests of diversity versus the interests of seeing if somebody has interpersonal skills. And I'm not sure, you do the best you can. I mean, what I said about being against the interview is sort of tongue-in-cheek. We're not getting rid of interviews anytime soon. I mean, people really value what you can get from an interview. But it does have that potential I think when I do an interview, I'm always thinking, can I work with this person? Am I comfortable with this person? Well, that's against diversity, because the people who are most comfortable with are the people that are most like you. So it's a negative. But I don't think there's any way around doing an interview. And you make an excellent point. The context you mentioned is exactly why interviews could be invaluable.
Well, many thanks to Dr. Wasserstein.
Thank you. Okay. Great. Sure.
It was good to see you.
Good to see you too.
I will have one of the